Uh, Good evening, everyone. I, Dr. Parveen Kaur, on behalf of Oncocritical Care Society, welcome you all. So, in continuation of our ongoing academic activities, today we are going to discuss very important topic, that is interpretation of culture reports. So it seems that what is so important about it, but I think lot of things depend. It helps in our decision making, and culture is to be interpreted very carefully so that timely treatment can be started. So for this discussion, we have Dr. Sanjeev Kumar with us. He's professor and head Department of Critical Care Medicine, Indira Gandhi Institute of Medical Sciences, Patna. Welcome, Dr. Sanjeev.
Welcome, everyone.
Then our second expert is Dr. Amol. He is professor and intensivist, Tata Memorial Center, Mumbai. Welcome, Dr. Amol.
Thank you.
Then we have Dr. Abhijeet with us. He is consultant in charge, Neurotrauma Intensive Care Unit, Ruby Hall Clinic, Pune. And we have Dr. Ritu with us. She is associate professor, Department of Critical Care Medicine, Indira Gandhi Institute of Medical Sciences, Patna. And we have our Dr. Saurabh. He is a senior consultant in Max Shalimar Bagh Hospital, Delhi. So without taking much time, we will start the session. So I'll ask Dr. Abhijeet. So whenever we are asking for a blood culture, we have ordered a blood culture, how will we ascertain that what is the sample is accurate or adequately collected? Dr. Abhijeet, please.
Can you repeat the Parveen, please unmute. Dr. Abhijeet, can you hear us?
Dr. Abhijeet, can you hear us?
I think the
Okay.
network connection is getting interrupted.
We can hear you nicely.
Is that question for me?
Yes.
Yes. So I'll repeat the question. Am I audible now? Dr. Abhijeet, am I audible?
Voice is getting disconnected.
The question is
Is it
about
only
the.
for me or it is happening?
We can hear you, Abhijeet.
Yeah, right. So can you repeat the question, please?
Yes. So the question is, when we have ordered a blood sample for culture sensitivity, how will we ascertain the accuracy and adequacy of the collected sample?
Like in any sample, like
Right.
be it like culture or like urine sample, like how can you ascertain that our sample is of good quality?
Right. So adequacy of the sampling will depend on multifactorial, right from the bedside where the sample is getting collected, how the sample is getting collected, whether the person who is collecting is a trained or is following protocols. Then the sample when it is reaching to the lab, what criteria they are following, right? So what are the things which they do? First is whether the sample was given in proper channel, collected in proper bottle, mixing done in proper. Can you hear me?
Yes, yes, we can hear it.
Yeah.
Yes, we can.
With mixing done in proper tubes, then whether the chain was followed adequately, and when the sample reaches, when the sample reaches, whether the labeling was correct, whether the barcodes have been followed, and then whichever the sample is there, particularly in high stakes fields like in critical care, when the sample is reaching with a proper labeling, proper container, proper volume, that is adequate or not. And then what physical examination they are doing, whether they are accepting the sample or rejecting the sample, right? When the sample is accepted, what test or what clinical history has been provided or not. One thing. Second thing, if the sample is not adequate, whether they have communicated or not. That is important things. Physical examination, if the sample is clotted or hemolyzed, or there is a icterus or lipemia is there, then the sample is inadequate. So these are the things where we find that to confirm whether the sample is adequate by volume, by label, and everything, and then physical examination. Then the third process, what we should do is the automated systems, right? Automated systems will see for, like I said, for HIL, hemolysis is there, or fibrins are formed, or icterosis is seen physically. These are the things where we should follow those protocols. And if we have considering for other sample, as Dr. Saurabh said, if you are considering for BAL or tracheal aspirates, then what quantity is getting, how the sample was collected again, and then what amount of cells are present. That will justify whether the sample was collected adequately, or it just a saliva sample which was sent. Whether if it is BAL, then the colony counts will differentiate whether the sample is adequate or not. If in haste it is collected by catheters, sometimes it happens that the sample is collected in haste, in emergency, and then sent. Then the proper infections protocols have been followed or not. That has to be certain. So
Many
these
a
are
time
the
while
points where we should.
taking a sample from viticulture, like using bronchoscopy is a bulk, like we instill sometime normal saline or water to get, and so there may be a dilution of sample. So how can we adjust that dilution by, like when we take blood sample or eticulture? Any anyone can, like Dr. Parveen also can you, have you got my question?
No,
Okay, then we'll move to the next question, Dr. Parveen.
Yeah. So, one thing I wanted to ask Dr. Abhijeet, am I audible to you?
Yes, yeah, you're audible.
No, Dr. Abhijeet, I think there is some.
Problem in a net.
I
no.
think so.
Yeah,
So, anyone can answer. So, what I was just asking, is there any time interval when we are collecting two sets of blood culture? Is there any optimum time which is to be it's to be given, or there is some specific time period if two sets of cultures are being sent? Is
Yeah.
anybody?
Uh,
So,
Actually, regarding time, hello, I am audible.
yeah,
Yes,
yeah,
yes,
yeah.
yes.
You are, sir.
If it say about the timing, so for the especially for the bacteremia, 2 to 3 sets of the aerobic and anaerobic sets should be taken and collected before the antibiotic given, and if possible, give through the different sites, and so that we can get the proper way of the year, and that should be the so basic thing is that we should take the good quantity, about the 20 to 30 ml of the quantity, and from the different sites, two different sites, so that will be the good thing.
Dr. Parveen, time will be important
Yeah,
when we send culture to detect catheter-related blood-stem
yeah,
infection,
yeah,
because
yeah,
Yes.
we need to know like which culture give first, positive first.
yeah, yeah,
So in that case,
Yes.
we have to take culture simultaneously.
yeah, yeah.
Yes. So, I would like to ask Dr. Sanjeev that how will we
Yeah.
differentiate between a colonizer once the culture is showing a positive report? So, how will we differentiate between a colonizer and a pathogen? Dr. Sanjeev, please.
So basically, this is the clinical microbiological correlation challenges, and basically it's depend upon the so many things that from where you are taking, and if the growth find from the sterile site like the blood, CSF, and the pleural fluid, so it should be the pathognomic. So and if you growth from the non-sterile site like sputum wounds and wound swab, and so it needs interpretation. So that should be understood. And regarding its quantity, so we should also take precaution about the how much growth is erupted, whether heavy growth or scanty. So it should be just find out on the basis of the semi-quantitative method or even the quantitative method in the. So on the basis of that, we can just find out that the what is the basically the severity of the things. And also we should also think about their clinical pictures, that what is the basically along with there is the inflammatory markers present or not, whether patient has the simultaneously present the first cell polymorph neutrophils, like things in a species. So that should be also we have to take in the mind. And we are should also understood that whether the patient has the what is the status of the patient, whether patient is the immunocompromised or the it is the normal, what is the status of the patient, that should be whether any sign or symptom of the infection like the fever or the local sign. So that should be the correlated. And uh, accordingly we have to take all these things.
Okay. So now we're moving to a bit antibiotic resistance. My question is for Dr. Amol. We all know that ESBL producer, they are concerned in our ICU setting. Many times culture report, they report ESBL about ESBL producer. Sometimes they don't report. When they don't report about the ESBL producer, by looking at the sensitivity pattern, how you know that this is the bacteria is ESBL producer and we can treat accordingly?
Yeah, I think it's a very important question. So when we are reading a culture report, we should not read just the last line, whether it's a sensitive or resistant. First of all, so I'm not talking about blood culture. I'm giving an example of a sputum culture. So if you are looking at sputum culture, you also should also look at whether the pus cells are present or not.
Yes.
Now, when you go back to the antibiogram,
Mm.
so you can look at the cephalosporins. So
Mm.
for example, so when we're talking about ESBL, we're talking about gram-negative bacteria. So
Mm.
if you grow any gram-negative bacteria,
Mm.
you look at the culture
Mm.
and so see whether the simplest thing is, if you are like a ceftriaxone.
Mm.
So it's a commonly used antibiotic to use for our community-acquired infection.
Mm.
So whether the organism is sensitive or resistant to ceftriaxone.
Mm.
Now, many times it happens that the organism is resistant to ceftriaxone, but we miss because we also see that organism is sensitive to cephalosporin sulbactam
Mm.
or piperacillin tazobactam, but it is
Oh.
resistant to ceftriaxone.
Correct.
So it's a very common occurrence, and we tend to ignore
Mm.
that the organism is resistant to second or third generation cephalosporin. So that is the
Mm.
hint
Mm.
which we can identify these organisms can be
Mm.
ESBL producer. So when we say ESBL, it's an extended spectrum beta lactamase.
Yes.
So that means the it will be resistant to cephalosporins, but it will be sensitive
Mm.
to a combination of BL, higher BL-BLI or novel BL-BLI,
Mm.
like tazobactam, avibactam.
Mm.
So these are the this way
Right.
we can identify the organisms which are ESBL positive.
Mm.
Especially in a gram-negative, it's common in E. coli,
Mm.
Klebsiella, but also we see it in other organisms like also in a species other organism like a Pseudomonas.
So, so
Not sure
as
about
per
Dr.
guide,
Yeah.
yes, Dr. You want to say something? Yes,
Dr.
Dr.
Ajay has made I had some comment. I don't
Yes.
know whether it's related.
Sir, Ajay sir, can sir asking like the drug of choice for ESBL producer is carbonum.
Yeah,
Right?
yeah. I'll
But
come to that. Yeah, I can. come to that if you want.
Yes, please, please.
So once we identify its ESBL, so it's very important that we should not miss ESBL, which is a resistant pattern to single cephalosporin, but sensitive to BL-BLI. Now the second thing is, even if you see that it's sensitive to, let's say, piperacillin tazobactam or cefeprazone sulbactam, which are commonest antibiotic that we routinely use, we should not be using these antibiotics. The reasons behind is, number one is it might be in vitro sensitive, in vivo it might be resistant, and the most important reason for it is known as inoculation effect. So higher the antibiotic load, these sensitive organisms can become resistant. And if we look at the studies, one of the studies was in the JAMA, which compared piperacillin tazobactam versus meropenem in patients these were hospitalized patients, not ICU patients. So traditionally we used to say that when you have ESBL, if patient is sick, we use carbapenem, and if patient is not sick, we can get away with a BL-BLI combination. But even in patients who are not very sick, like hospitalized patients, they had found that higher mortality, almost 3 to 4 times more higher mortality in patients in whom we are using piperacillin tazobactam, for example. So the drug of choice is absolutely right. Ajay has mentioned it is carbapenem, which is restricted to meropenem or imipenem when we are talking about ICU patients or ward patients. Occasionally, if you have a practice where you are doing an outpatient treatment, which is not common in India, but above people are using artapenem for outpatient treatment.
Artapenem, okay. So, thank you, Dr. Amol. Next is question is for Dr. Abhijeet. Dr. Abhijeet, can you hear us?
Can you hear me now?
Yeah, I can hear you.
Yes.
So it's very important question for all of us, since because of the antibiotic resistance, even 50% cases the organisms are resistant to carbapenem. Then we have only option like colistin or testosterone. Now problem is that nowadays for last 2-3 years we can see they don't give sensitive to colistin, they just give intermediate to colistin. So when we give like when I prescribe colistin, the other people they ask us, since it is not sensitive, then why are you giving us? Sir, can you explain us like why they have stopped giving sensitive to colistin, and like even if they are not giving sensitive to colistin, can you still use colistin?
Yeah.
Yeah.
Colistin, because nowadays what we are seeing is the newer antibiotics definitely are not coming, not in this pipeline. We need to save the drug. One thing. Second thing is colistin testing. It is difficult. It's not easy. The whatever testing is getting done was getting with the commercially available days or the medias. The drug itself binds with the plastic and diffuses with the poorly in the agar. So what they have recommended is colistin to be tested only by the broth microdilution method, right? And it itself is a cumbersome, labor sensitive method for the colistin particularly. And UCAST and CLSI guidelines have specifically mentioned not to give sensitivity to the colistin, right? So whatever they are suggesting for doing by the BMD by broth microbiological method only, and they have raised the MIC levels more than 2, more than 4. They are saying to give it either in intermediate or resistant. So this is the thing they have mentioned because of saving the drug. Still, we can use those drugs in XDR. We need to ask them if we need sensitivity for the colistin or polymyxin particular. Then only they will do it and they will let us know. The commercially available which were there, all the things have been withdrawn. They have been strict guidelines and mandates have been issued by these authorities for not giving colistin sensitivity reports, unless specifically asked for.
Sir, is there anything related to breakpoint? Because in our lab they give MIC report that is less than zero point 0.2, but still it is intermediate. Is there anything related to breakpoint of sensitivity?
So I'm not getting your question.
Sir, actually, what I wanted to ask, like in our lab, they give MIC value of
Right.
colistin. There sometimes it is less than zero point 0.2, but in spite of that, they don't give sensitive to colistin. Is there any relation to the breakpoint? Like, uh, I think the CLSI have stopped giving breakpoint for colistin like that. Anything like that, sir?
Yes, sir. Yes, sir. They have stopped giving breakpoints in view of avoiding the overuse or misuse of the drug.
Mm-hmm.
That was the main reason to preserve and conserve. The colistins have been misused and overused, and because of that, the resistance have gone high. Because of its the efflux pumps, the resistant mechanism, the MIC, the MCIs, the resistant mechanism for the colistin have gone up. To save that, in cases of very highly or XDR cases, the colistin is preserved.
So,
Did I answer your question?
okay, thank you, Dr. Abhijeet. My next question is
Yes.
Dr. Sanjeev is again about colistin. There is a nice guidelines was published in 2019 how to use colistin and polymyxin. They recommend to use colistin with combination. If we have a sensitive antibiotic, combine with that. If not, then combine with a antibiotic even it is not sensitive. So in that case, how can we uh, choose antibiotic to combine with colistin?
My hello.
Yes,
Yeah.
Yes, sir.
It's more for me.
yes, sir.
Yeah.
Yes,
Yes.
Dr. Sanjeev.
Uh, Actually, if we talk about the cholesterol, basically, most of the time we use in the combination. It's not such drug that which can use solely. So because of the we take advantage of the synergism. So most of the time we use in combination with the carbapenem. So especially for the gram-negative cases, so as you know that the carbapenem work on the bacterial cell wall and the colistin on the bacterial cell membrane. So it's both in it work as the synergistic effect and the kill bacteria like so. Most of the time you use in the combination, even in the heavy infection, yeah, just a gram negative severe infection. There, the chances of the mortality is very high. In that condition, we use the dual gram negative coverage, like cholesterol along with the cholesterol, and as well as you can also use some more drug like just TG cycline, aminocycline. So in this way, we can use the. But the recently, I have also seen that the latest edition of the Sanford also recommended that you can use again carva without carbapenem. So, but in the practical day by day, you use the as a combination drug.
In your clinical practice, what combination you use often?
Most of the time we use in the like the Acinetobacter infection. So in that condition, we use the carbapenem along with the
Do you use salvectam also?
yeah. In high dose of the salvectam is also recommended if patient is sensitive.
Thank you. Thank you, sir. So my next question is to Dr. Amol. Another drug were extensively used in carbonum resistance organism is Deshmukh. But here we do test for Deshmukh, but most of the time it comes resistance because of
Yeah.
and because mostly it's an NDM gene. But still, assuming that combination will work, combination with astronome, it will work. So we give. But in when there is no synergistic test, how can you justify in like court of law or in before the attendant that we are using receptor astronome? Even they have drug coming resistant.
Yeah. So I agree with your concern because currently we are also looking at the medical legal aspects of treatment, and we are dealing with patients who are very sick, and many times the patients and the relatives, they also get the reports of the EMR on their mobile, and then they share with someone or they discuss and they say, "Ki, okay, this is showing resistant, but how you are giving it?" And it becomes very difficult to justify how why we are doing it. Logically, when we are talking about metallo-beta-lactamase, for example, or KPC or ESBL, diacepta astronome is a good combination because one astronome is going to inhibit the metallo-beta-lactamase, and the ESBL and AMC other resistance will be taken care by the IV vaccine, and that way you are going to have an additional cover. But yes, I agree with you that
What is the sound
you are,
behind this?
yeah, we can unmute the other. So it's very important to have synergy
Yeah.
because many times it is resistant. When you see the individual report is resistant, but when you have a synergy testing, it may come positive. And if we are giving it without the synergy test, it's like driving in the dark.
Correct.
So it might be either sensitive or resistance. We don't know.
We don't.
And even when we say it's a sensitive, still
Yeah.
almost it respond to 70 to 80% of the patients. The 20% percent of the patient may still
Yes.
worsen.
Mm.
So it's so if your microbiology lab is not doing the synergy test, you can ask the lab. Now, most of the times, if you contact the drug companies, they are very happy to share the e-strips.
What
And
strips, sir?
this e-strips
E-strips, okay.
for the testing of the
Synergistic.
synergy.
Okay.
So where both the drugs, so they look at the area of inhibition with the individual drugs and the combination of drugs.
Combination.
Yeah, and there is a significant reduction in the area, increase in the area of inhibition, and that way the microbiologists can easily identify whether synergy is present or not. And then if synergy is present, then you are obviously justified. And as Dr. Sanjeev has rightly said, we should spare cholesterol to the minimum. Even Dr. Abhijeet also has mentioned that the cholesterol should be avoided as much as possible. So we are trying to do this antibiotic rotation or stewardship where we are trying to identify the drugs which can be given, avoiding the cholesterol both for the nephrotoxicity and also to keep cholesterol as a last resort. So yeah, I completely agree with you. The synergy test is very important for us for clinical management, and also obviously in the court of law. By any chance, if someone that is the case, obviously we'll need to have something on paper.
Okay. So, Dr. Parveen, will you ask the next question? Dr. Parveen?
Yeah, you can carry on, please.
Okay. So,
Yes,
this,
yeah, carry on, please.
so
And
another
just one quick comment about the cholesterol sensitivity and resistance, if you allow me.
Yeah, please.
So, like the cholesterol by itself, the drug is high molecular weight cation, so it doesn't get diffused in the disc. So that's why the recommended when you talk about if you want to report sensitivity, has to be done in a broth dilutions, and it's a very tedious process in a serial broth dilution. So nobody, I don't think anybody is doing it. But when we are looking at the MIC of or whether it's intermediate or not, it's a very good way to have come to know about the flora of your own ICU.
Mm.
Like because most of the time when we give colistin, we are not giving as per the report. We are most of the time many times we are giving as an empirical agent when our initial antibiotics are not working. So maybe 48 to 72 hours patient is still worsening. Where and we know from our experience that colistin works very well in resistant organisms. So that's why it's important to know for us what is the epidemiology of colistin or the local flora, whether our bugs are sensitive to colistin or resistant. So that's very important. So we should have that data, and every monthly we can review along with the microbiologist, so that it can decide help us to decide the antibiotics.
Dr. Amod, can you get help of the multiplex PCR tested?
PCR testing will only tell you about the resistance, but when you
No,
yeah
multiplex PCR in which we can get also along with the all sorts of the microorganisms along with the gene resistance like biofire or all this thing.
yeah. So all these PCR, so they are only amplifying the genes which are present. So they will look at the specific gene, whether it's ESBL,
Yes.
KPC.
Yeah.
So they will identify. But it's important to correlate it with the culture,
Clinical.
Yeah.
clinical and culture correlation, because it's your PCR might tell you. So it is going to amplify even a small, even if a one or two organisms with that. If you have,
That
for example, in polymicrobial infection, most of the resistant patterns will be positive. But then you have to correlate clinically and look at the positivity of the culture
that should be
or
rule out.
what grows. Because PCR will not. So, like for example, we learned this in COVID. So we used to get so the patient used to be COVID positive for 15 days to 1 month. It took us a long time to realize that the patient is shedding the dead virus, not the live virus, and that's the biggest problem of PCR. The only test that tells us about which is a viable bacterium is the culture. PCR only amplifies the genes present. So we need to take both this thing, correlate the clinical finding and then decide.
My next
So I think
question
Dr. Ajay has made a nice
Yeah.
comment.
Yes.
The PCR creates the confusion and culture confirms. So
No,
I think
actually, in our center at IGMS Patna, last year we are use most of the case, and one topic is also given that the use of the PCR in PCR multiplex PCR, that is the biopire, comparison with the conventional microbiological test. That is so that's given a little bit the good picture. So actually, in that case, we send both the sample, and on the basis of the if they find the culture positivity report, so on the basis of that they do PCR, and in this way we get the earlier the report and with the all the details. So that is the main advantage, although it is a costly, but that is the beneficial.
I think cost is the key word here.
Yeah.
So for many of us who are working in a government setup with poor patients, with minimal grants, or in private, where each and every rupee counts, we have to justify for each and every investigation. And
But
even
these-
if you are doing in-house PCR biofire, at least the cost is minimum 10,000.
Yeah.
Yes, it is.
If I'm correct. So very difficult to.
But if you can avoid the use of the unnecessary antibiotic, on the basis of that you can justify the things.
And actually, in ours, carry on, please.
Yeah. So another, that you're about the topic that we're discussing, colonizer versus infection.
Yeah.
So when you do PCR, it's very difficult. So in culture, it's difficult to differentiate between colonizer and infection. In PCR, is the most difficult.
Yeah.
any bug it's going to grow in PCR, and then so we'll be finding ourselves in a difficult situation to
That's are the
decide which
shortcoming.
antibiotic. Yeah.
That's are the shortcomings, but in spite of that, there are a lot of the advantages.
No, but yes, I also agree because see, ours are we have a cancer center, so definitely I think many of us are working with these immunocompromised patients. Sometimes it gives a really valuable clue.
Yeah.
PCR it is important, but of course, clinical history and examination and in the context it has to be used very appropriately. And whenever you are getting the culture report, then we have to modify our treatment according to. At least we'll
Yeah.
get some clues sometimes.
Yeah.
So
Yeah. Yes.
and I think over the time when we are using it we'll be in a better position to use these tests appropriately.
Definitely.
May I add to this?
Yeah.
Yeah,
Yeah.
please.
So I work in a cancer setup, and we get
Yeah.
many patients who are neutropenic, and
Yes.
especially the children, also in adults. So we are frequently doing respiratory biofires for our patients
Yes.
who are coming with the respiratory
Oh.
symptoms, and many times we pick up not only the bacteria, but also
Viruses.
we have viruses. And for example, rhinovirus is a very common,
Enterovirus.
and yeah,
Mm.
Nowadays we are looking more of rhinovirus and enteroviruses.
yes,
Even,
And
even,
today only,
even fungus.
yeah, today only we have a patient, CA breast, just neutropenic, received chemo around 8 days back. She came with some respiratory distress and all those complaints, fever, loose motion. So we sent our panel and she was detected to have this human metapneumovirus. She was on
yeah, that's
NIV,
also
X-ray. So sometimes yet it is helpful also, but I think clinical context always remains the key.
Yeah.
And another point in these patients is when you're saying looking at the respiratory, it's also important to send the nasopharyngeal swab, because most of these
Absolutely.
organisms you are going to identify nasopharyngeal swab, and they may not identify them in the tracheal aspirate or the bath. So you need to send the nasopharyngeal swab also.
Uh, we have also Dr. Ajay Gupta. He is the HOD of Max Shalimar. If you want to add anything, sir. Ajay, sir, if you're here, still here, and if you want to add, please add. Or any comment? I think he is not here. Okay. Move to the next question to Dr. Abhijeet. Dr. Abhijeet, are you there? I can't see you.
Yeah, yeah.
So, uh, believing blindly on the cancer report may be sometime problematic, because sometimes uh, bacteria may be sensitive in vitro, but in clinical setting it may not be sensitive. Sir, can you give some idea? Can you give some example, like when a bacteria can be in vitro sensitive, but clinically it is not sensitive, and we should not use, and we should consider this while prescribing our antibiotic.
Hello, can you hear me?
Yeah, we can hear you.
Yes, we can hear you. Please carry
Yeah.
on.
Yeah. So, in vitro resistance or high MIC, but in vivo efficacy or the vice versa, uh, mostly is because of the host immunity, pharmacokinetics, or biofilm disruptions, or because of the inoculum effects, which will be difficult to get captured in the testings. So sometimes, like what we said about the colistin is given as resistance or intermediate, but in some cases wherein resistant organisms or XDR infections, we need to consider giving combination therapies. So in certain cases, like treating Acinetobacter baumannii or Pseudomonas aeruginosa, even if the patient the report antibiogram shows resistance, but we need to consider giving combination therapies, and depending upon which site of infection we are treating, that also adds on to the choice of the antibiotics. uh, Sometimes increasing the doses depending upon the clinical condition, in shock state, or where we say VD by VT, in that cases we might have to go with the higher antibiotic dosing to get the good synergy, despite if we get a resistant organism in the reportings. To give example, like colistin atisate with the combination therapies, even piperacillin tazobactam, in some cases it might respond to, despite the MICs being more or more than 16 or 24, for tazobactam might work, or in combination, while like we can do piperacillin tazobactam combinations or ceftazidime-avibactam along with the polymyxins. These are the combinations where we can use despite being resistance. So in synergy, consideration for the patient host, patient factors, inoculum effect, biofilm effects, all these will help us in deciding where if we can go ahead with the use of that antibiotics.
So many times,
Apart,
like we see in
apart
the
from this, I think a site specific is the one of the things
Right, right,
like
sir, right, sir.
mm,
yeah, correct.
like UTI and fosfomycin is the better drug, and
Yeah,
the
fosfomycin will achieve more concentration in UTI. Like,
nitropron nitroprontine is the better
right,
working.
right.
Yeah,
Prostatitis, the
yeah,
fluoroquinolone is better.
yes.
Okay.
Plasmacin is for mainly for E. coli, so
Yeah.
bacteria should not use. And again, like many time we see UTI caused by enterococcus, and
Mm,
it shows sensitive to also linezolid, teicoplanin, and all.
yeah.
But we should remember that linezolid urine excretion is very low. It is
Yeah.
Yes.
it is 40%, less than 50%. So we should try to give some antibiotic that has a higher renal excretion, maybe daptomycin, maybe teicoplanin. So
Yeah.
this may be a consideration while prescribing uh, antibiotic. So Dr. Parveen can answer next question.
Yeah. So my next question is for Dr. Sanjeev. So there is a post-op patient. He had some fever. TLC is high, but he has all the lines: art line, scent line, and dialysis catheter. So when we order for a blood culture, how should we send for blood culture? Which line? Where to take the blood culture? Dr.
And how
Sanjeev,
many actually?
please.
How many
Yeah.
samples?
Yeah.
And how many? Yes.
Yes, actually, regarding this, we should remember, we should just know about the what are the catheter-related blood stream infections protocols. So that thing we should remember. So ideally, we should send the two sets of the blood culture, 4 bottles in total, and the peripheral venipuncture should be done, preferably in the opposite side where no line is inserted, and the simultaneously send the 2 bottles and from each lumen of the central line, and each central line and the dialysis catheter. So and the quantity should be good, not less than 20 ml. So and that should be inoculated and send to the microbiological lab. And if the arterial line is also inserted and the site is infected, that should be also considered. Also, there is high flow, but that should be also the considered for the yeah. And we should also think about the idea of the and the proper labeling is the most important. If you are sending the drug, so that that proper labeling, that this is the from the distal end of the central line catheter, and this is the from the what are the from the which arms. So that should be clearly written on the label. And we should also think about the differential time of positivity, especially if you are taking from the central line and peripheral line, and in central line it come earlier report. So that should be, I think that it's the its report is the justifying. So that's all the thing about the how you have to think how much quantity and what the way. So naturally the proper aseptic precaution, all these things should be taken.
So, sir, you recommend to send sample from the all lines
Yeah,
along with the peripheral,
yeah, yeah.
peripheral side. Sir, do you recommend to send for both aerobics and anaerobics, or like only
Yeah. No, no. We
both?
should
Both.
send both aerobic and aerobic too.
Aerobic
Yeah,
from all the
yeah, yeah.
sides.
Two. Yeah, yeah.
So total 8 vials almost we need. Right?
At least 4 vial is the
For,
compulsory, but
okay. So this is my last question, and it will be for Dr. Amol. This is about the fungal infection. The question is, I have this question because the recommendation is that when you have bloodstream fungal infection, you give antifungus 14 days after it become negative. So that means once you start antifungal, then you have to scan culture repeatedly so to find the negative culture. And it is not possible in our setting to send culture every day. So in that case, what do you do? What is your recommendation? Like how often, how frequently you should send culture after giving giving antifungal?
Yeah. So once you identify the fungal infection, I think the most important thing along with antifungal and culture is the source control.
Sorry, sir?
So
Again?
most of the source control.
Source control. Yeah.
So most of these patients will have at least a central line or a PICC catheter or a Hickman catheter.
Mhm.
And especially if and in these patients, we need to think of removing the catheter, because unless we remove this source, we are not able to get the negative culture. That is number one. Number two, you can, if you obviously see, we also don't send the culture every day. We are sending at least 48 to 72 hours. And once we get the negative culture, we obviously we don't we continue antibiotic for 14 days. So if you are, so I think alternate day is a reasonable strategy.
Mm.
But importantly, before that, you have to do the source control. Also check for the also check for the source, like mm, endocarditis. If you're suspecting endocarditis, so also look at the echo whether there's an endocarditis present. No, and I said 2 days, but some you can also send it in 3 days. I think Dr. Ajay has mentioned a comment that 3 days is fine. I agree with you, Dr. Ajay. Even 3 days is a reasonable choice.
So after third day, you should send culture. So this was with a question that I have, like based on my confusion while prescribing antibiotic and while interpreting a culture report. If you have anything more to say, more to add, like that we didn't discuss so far, you can always please.
Yeah. Actually, I would like to add one thing. See, we write blood culture very frequently, but sometimes we have to see our nursing staff how they are collecting samples, because that is very, very important. As everybody has been mentioning, the proper technique of collection makes lot of difference. If they're not cleaned the port, they are doing something, and I don't know what about other ICUs, but ours is normally not 1:1 ratio. So it is really important, I think, making them understand what is the importance and telling them that you have to take the sample before you give antibiotics, preferably. So I think that also will make the difference. So that remains very, very important part, because they are the person who are actually collecting the samples and sending it to the lab. So proper training, that remains very, very important part of this if we want to have good results with this.
Yes, most of the time we also use the just at the time of the insertion of the central line, same time we just take out the blood and send the. But the main problem is that the patient is already taken so many antibiotics before the
Yes.
admission. So that is the very difficult situation, that how we have to analyze it. So that is the another problem.
And recently I have observed that once we asked for a urine culture, and sister just took it from the urinary bag and just poured it and then she was sending. So I think these are minor things, looks like minor things, but that makes a lot of difference as far as management is concerned. So we have to be very careful. We are taking the samples.
Yeah.
Right. Just may I add one thing? What we are doing in our setup
Yeah.
is we do I ask either the PGs, right, the critical care trainees, or the senior most sister who is in charge at that time on the floor, will either supervise, take responsibility for collecting the cultures, right, and will mention the numbers. So if that helps. It's not to blame or point out, but that helps in
Yes,
training purposes.
absolutely.
The positive culture and clinically relevant cultures definitely have improved in certain, but definitely in these scenarios where we can't take samples repeatedly, like what you said before giving antibiotics. Supposedly we need to send repeat samples, then it becomes difficult, like done on BAL or done on CSF, it becomes very
No, that
difficult to
is,
collect again samples.
yes.
So, thank you. Any comment from Dr. Sanjeev, Dr. Amol? Last comment.
So one thing that we sometimes forget is, for the culture bottles itself, they can grow organisms. So it's very important to
Yes.
clean the rubber corks of the culture bottles, because especially if you are dealing with a patient who is neutropenic or severely immunocompromised, we have to respect each and every bug which we can discard in a patient as a contaminant in a
Right.
immunocompetent patient. So
Yes.
full aseptic precaution, full skin preparation, and even the culture bottle, they need to be cleaned well with the spirit, so that we don't grow any facultative organisms and we are growing only the pathogens.
Nowadays, there's a ready-made culture bottle is come with all the its content. So I think that chances is reduced nowadays, and that is the very much sterile technique to come. So, but
Dr. Saurabh, any comment that what is more important, the volume of blood collected or the timing of sample collection? Does it make any
Both.
difference as
Both.
well?
Yes. Yes. Both. Because
And
volume,
both.
if you give more volume, the sensitivity increase.
yeah,
You will get,
Yes.
again, there is a possibility of getting more
Mm,
bacteria. Again, then
yeah.
time earlier the sampling is better than better, always better.
Yes.
So both
And
are
then
the most.
sometimes if the patient is conscious enough, then they will think कि हमारा सारा खून निकाल
सारा
लिया
खून वही
डॉक्टर्स
ले
ने.
लिया. Like, if you then, like Dr. Sanjeev said, if you send four blood
Mm,
sample, then it will be
mm.
lots of blood.
And
And
it
I think
happens.
nowadays consultants have also started saying कि आईसीयू में रह के पेशेंट का तुमने खून कम कर दिया. So I think that also.
But
Further,
Particularly
So
in
further
immunocompromised
anemia.
patients.
but after admission in the ICU and 1 to 2 days, naturally the hemoglobin is a little bit down.
yes,
Yes.
Yes, that is the
yes,
ongoing process.
But I think we have to find the balance between the how much blood you are going to collect based on diagnostic yield, and also the patient's weight and hemoglobin level. Because if you see, like these guidelines of minimum 20 ml or more, they are the Western guidelines where the patient's average weight is more than 70. Our patient's weight is less. Many patients are anemic to start with, and in cancer we are dealing with patients who already can
hardly
have a
have it.
pancytopenia. So we need to find
Yes,
our own sweet spot or a balance,
yes,
how much volume of blood we need to collect and how many sets we are going to send. And
Is
I
there
think that we can discuss with the our own microbiologist,
microbiologist. Yes,
and look at the cultures and the positivity, and then maybe we can come to a conclusion based on that.
Sir, is there any recent guideline published that in which such type of the recommendation is that because we also teach our DM student that this is the protocol and you have to stick with this thing. But if there is a guideline that low hemoglobin and the low weight, in that condition we can also recommend. So actually, I have not seen Dr. Amos.
Yeah, so I'm not aware of any
Yeah,
guidelines as
yeah,
such
yeah.
which say that you can get away with a less volume.
But unfortunately, we have to stick with the such type of the guideline because sometimes we tell our DM student that you give this thing, but they tell the sir, but according to guideline, I mean, just follow guideline.
So that's
Nothing.
what. So guidelines are us for to give some pathway, but we can
Yeah,
modify based on our
our clinic
experience and
no,
and
no,
our subset of patients.
subset of
but
patient, and also if you discuss with your microbiologist, you will have a better insight at what should be done. And both microbiologist and the ID physician
ID
Mm.
physician,
and
yes.
and the intensivist.
ID physicians are not available all the area, but microbiologists also depend upon us. They are only the
Yeah,
microbiological aspect, not clinical knowledge. So that is nowadays we are making more rapport. So they are the learning with us, and we are learning. We also send our DM student to microbiology department that learn the what is the process and how we have to uh, improve the things. So that
in
is
the
the
hospital,
another.
yeah.
Yeah,
In the
yeah.
hospital where there are no ID physicians,
Mm.
intensivists automatically become the ID physicians.
Yeah, yeah,
ID
yeah.
And
physician,
you
yes.
and you start getting calls from the even wards.
Mm.
Sir, this is the patient we had grown this bug. What should we do? Should we
Mm.
isolate? What antibiotic we should give?
Mm.
What combination we should do? So yes, of course, we should have the knowledge of ID at least to help our patients
Mm.
better.
Definitely.
Yes, absolutely.
Agree.
So I think we can wrap it here.
Yeah.
I would like to thank all of you for joining us today, Dr. Sanjeev, Dr. Abhijeet,
Yeah.
Dr. Amol, and all the participants, Dr. Saurabh. Thank you
Thank
so
you.
much for
Thank
this
you, everyone.
insightful
Thank you.
discussion.
Thank you, everyone. Thank you for joining.
Thank you for inviting.
Thank you, airlines,
Nice discussion.
giving me
Yeah, give the
opportunity
opportunity
to.
also. By the way, which was the airline?
And actually, at Patna, there is a very huge cloud, bad weather. So all flights are cancelled. So
Thanks for
tomorrow,
the
most
airline and
probably,
thanks for the weather also.
yeah, yeah. All
Thank you.
airlines. will.
Thank
Okay,
thank
thank
you.
you.
Thank you.
Bye.
Thank you so much.
Thank you, sir.
Good night.